and welcome to Quality Round. My name is Lee Fairclough. I'm the Vice President of Quality Improvement here at Health Quality Ontario. And thanks once again for those of you that are joining this series on a repeat basis, and for those of you who are joining for the first time, hope that you enjoy our round sessions today. This session is going to focus on transitions between hospital and home, achieving a standard of care. What you're going to be hearing about is the draft quality standards that HQO will soon be finalizing for release. And you're going to get a little bit of a glimpse into the evidence that underpins that, some of the discussions that happened in the development of it. And then you're going to be learning a little bit about an example of how some organizations are starting already to bring elements of that standard to life in the care of the patient. So our learning objectives are, first of all, to review the latest evidence to make transitions between hospital and home easier, learn about the standard and how it can support teams working to build a more integrated system of care. And then finally, we're going to hear from the experience of Thunder Bay Regional Health Sciences Center and how they've improved their discharge process for patients and families by proven to them process co-designed with patients. Before I introduce our speakers today, I'm just going to do a very brief reminder of what our quality standards program is here at HQO and what a quality standard is intended to do. Really, the quality standards highlight from an evidence perspective, what are some of the current gaps in care. It creates statements of what our target for care should be. All of our standards include a set of indicators and metrics that can support people as they're working to implement and work on improvement. Each standard includes both a general guide that's really ideally suited for those working across the health system, and then we've also developed a guide that's for use by patients, families, and others that may be involved in care. As well, each standard includes a getting started guide, a set of data tables, and really importantly, we've done our best to think through what it would take to adopt this standard in the province. So that's at the highest level what our quality standard includes and what it's meant to articulate. Without further ado, I'm going to introduce our speakers for today. I'm going to introduce two of our speakers first, and then I'll introduce our third speaker just a little bit later in the program. Dr. Amir, first of all, these two members that I'm going to introduce to you have been the co-chairs of the development of the standard and worked with a panel of volunteers and experts in its development. Dr. Amir Ginzburg has led many cross-sector improvement initiatives in primary care, the community, and long-term care. And he's currently the Mississauga Halton Linz Clinical Quality Lead, which has been a joint position, actually, with Health Quality Ontario as well. He's one of our HQO clinical leaders as well. He serves as the Program Chief and Medical Director of the Medicine Program at Trillium Health Partners and is a Master Facilitator for Patient Safety Education Programs in Canada in partnership with the Canadian Patient Safety Institute. For those of you that have not attended one of Amir's quality improvement sessions and where he's talking about quality improvement and safety, I highly recommend it. And as a specialist in internal medicine, Amir is a frontline healthcare provider for patients transitioning from hospital to home. Thank you, Amir, for joining us. Our other speaker today is Lianne Jeffs. She's the inaugural Research and Innovation Lead and Scholar in Residence for Nursing and Health Disciplines at Sinai Health Systems. Lianne has extensive leadership experience and an impressive track record in clinical and health services research with a focus on quality improvement and patient safety. Her program area of research focused on improving care transitions for patients with complex needs, optimizing the use of performance data to drive quality care, and translating evidence to enhance quality care, organizational learning, and health system performance. Needless to say, we had two very qualified chairs to take this on, and I welcome them to the podium.
So thank you, Lee. So Lianne and I are going to tag team this. So it's our privilege actually to be here representing the advisory committee who supported this work. And Lee, as you mentioned, we had rural, urban, suburban representation, cross-LIN geography, all across Ontario representation, multiple disciplines of patients, providers. We really had, I think, the world-class A-team to support us, along with the HQO staff, in helping to develop this quality standard. So as we go through these slides, what we'll start off briefly is just anchoring, why is it that we need a quality standard for transitions from hospital to home? What does home actually mean? So we'll start off just by referencing here that this quality standard in scope is transitions of care for all ages, going from hospital to home, where home is really defined very broadly as the place where someone lives, their usual place of residence. That could be a home, a senior's residence, long-term care, complex continuing care. It could be lots of different places, but these transitions from hospital to where you normally reside, they're fraught with potential challenges and risk. We thought that this quality standard would provide a framework for others that may follow, that may focus on specific populations or specific transitions. So for example, transitions between mental health and home, emergency department to home, inter-hospital or intra-hospital transfers, the whole concept of ALC, that's not really within this scope, but may follow in the future. So with that, care transitions can be fraught with challenge. We know from our experience as providers, as leaders, as people working in the system, but also ourselves as patients, that there can be voltage drop in services going from acute care to subacute and beyond. There can be communication gaps and challenges. And so really, care transitions are a very important target for better system integration. When we developed this, we had that in mind. We had many patient stories in mind, and it helped to forge kind of the anchor of the why. But let's talk a little bit more about some specific data. When we look at the aggregate, there's about 1 million hospitalizations in Ontario every year. There's a lot of transitions in this particular point across different sectors, from acute care to outside of acute care. This is quite a significant number. And we know that in 2018, when we asked people, 66% of Ontarians who were surveyed reported that their provider involved them in the decision-making as much as they would have liked to have been involved. It's not a bad number, it's a pretty good number, but there is definitely room for improvement. I'll tell you that as a patient, and I've been a patient in the acute care system, and I'm a provider in the system, it's interesting how when you're at your most vulnerable, you may want to be more involved, but there's deference to expertise, there's trust in others. It's sometimes hard to advocate for yourself. I know that one of the prior CEOs of Canadian Patient Safety Institute, Hugh McLeod, he's written about his experience as a patient where he's championing a national campaign on hand hygiene, but didn't have enough of the courage in his most vulnerable moment to ask providers, did you wash your hands? So there is a greater need for patients to be involved as much as they would like to be in their care, particularly around transition points in care, which subject them to a significant period of risk. We know that the percentage of people who reported that their provider, who usually gives them care in the community, knew about their hospital discharge and the particulars around that transition, that proportion also is, I would say in the aggregate around 70%. It should be really higher. Right? We know that this transition point is fraught with communication challenges, and there's an opportunity here. When we look at the divide between urban and rural, interestingly, in rural settings, this number is actually higher, where the communication across this transition point is a little bit more robust. We can theorize as to why this may be, but in smaller communities, the transition point and the continuity of care seems to be more well established. And that could simply be because of the consolidation of patients and providers in a tight working relationship. When we look at what could be outcomes of transitions that haven't been very effective, we can see a revisit rate to the emergency department within 30 days that is significant, somewhere in the 5% or above. And we see a readmission rate or rehospitalization rate in the first 30 days that's in the teens. Again, we know that some of these are avoidable revisits and rehospitalizations. Some of them are appropriate, but it calls into question the effectiveness of our current integrated systems for transitions of care from hospital to home. Further to that, when we look at home care across the province, on average, most patients, around 90 to 100% of patients are receiving their home care services at about 4 days. So there may be a wait in getting services when they come home. For those of you who provide care in the community or in hospital, you can understand what this number actually means. There's people who may need service on a very near-term basis, who through the complexities in our system and resourcing and other challenges that have been well known to us over time, they may not be getting what they need in the amount that they need at the timing that they need it. And that may give rise to revisits and rehospitalizations back in acute care. So we ask ourselves the question, is 4 days appropriate for the significant challenges in the patient population that we see? I'll turn it over to Lianne. That's data, but we actually went and spoke to a lot of people to share with us their experience as patients, clients, residents in the system around this transition point to help anchor what we then developed as the 10 quality statements in the standard. So maybe, Lianne, you can walk us through some of the concept mapping.
Yes, so thank you very much, Amir. And this sort of picks up on some of the comments that Lee had already said in terms of the purposeful engagement that we did in this quality standard by engaging patients and caregivers from across the province. And this was done with the intent because there's really not a lot of research that exists in Ontario around what the patient and caregiver's experience is around care transition, and we knew that this narrative really matters. And so the work was undertaken by Dr. Tara Curran, who led a concept mapping from across Ontario in 2018. And what we learned from this narrative, the shared narrative, really helped inform us in terms of giving the context of what the experiences are of those who live in Ontario, the caregivers and patients, and their care transitions across the various points from hospital admission to discharge home, wherever home may be, and just really also really influenced how we looked and shaped our quality standards 10 statements, which we'll share a little bit later. So specific to this development, Tara Curran's group engaged healthcare and community organizations, and as I mentioned, did a very broad stroke engagement of patients and caregivers from across different places and spaces. There was 2 phases. It was a multi-phase study approach, and the first phase really focused in on interviewing patients that have been admitted overnight over the last 3 years, and they were asked about the factors that affected their experience, because we felt it was really important to understand exactly sort of the barriers and or enablers that they were experiencing. That would be a huge source of evidence in addition to the quantitative data that Amir went over. And again, the broad stroke of the home was where people live, and so it did take into consideration people from shelters, people in long-term care facilities, people in residential, and so it was a very broad, in addition to those who actually have a home that they live in as well. So as you can see from this slide, this kind of gives you the data, and I'll tell you some of the key themes from the work that she did. But again, it engaged over 665 surveys, and of the surveys, 40% were patients, 53 had been caregivers, and 5 were a combination of patients and caregivers, as Amir alluded to. Many of us are both, and many of you in this room are probably, and who are listening in, have been a patient and a caregiver for someone who has been transitioning. So from this analysis, 52 unique concepts emerged from, as you can see, 2,704 ideas. So people really brought forward their ideas. They shared their narrative. They shared their lived experience, which really was a unique feature of understanding the context, but also evidence in informing us as a group on what we ended up coming up with the 10 statements. So really, from that, there was really, not surprisingly, similar to what has already been mentioned, but there was concepts basically around the continuity of care and how to prepare for a successful discharge, including discharge planning and process, timely services, and logical support after discharge. Also, coordination of care in the community, looking at follow-up medical care, home care, community-based rehabilitation, medical care. Out-of-pocket expenses came out, and we spent a lot of time as the group talking about where to fit this in, and you'll see this in where it falls out in the standard, and limitations of funded services as well. In addition, people also reported that there was challenges in home care in terms of consistency, reliability, sufficiency, and timeliness. Many relied on family, friends, private services, and/or charities to fill the gap, and that's a really important piece that we actually had a lot of time and thought put to. And the second most common theme was related to challenges, again, with the discharge process in terms of insufficient communication, lack of patient caregiver involvement in the process, and timing. So the second phase that was undertaken by Tara and her team was really, involved a smaller amount of individuals, but still enough that we felt actually gave a really nice representation of our province. But they were asked around which issue would lower your confidence to care for yourself as patients or as caregivers, and which areas should be prioritized for improvement. And so from here, you see there's 8 concepts that really emerged to sort of address that too, that sort of brought together really the range, again, sort of consisted from the first phase, the lack of funding that was available to support service and community-based rehabilitation, such as physiotherapy and occupational therapy, but also a shift on advocacy, service, and care coordination to the patient and caregivers. And they had to pick up, as was already mentioned in the first phase, but this came out again in terms of that there's a shift in the focus to those who are providing care to, from those providing the care to really plan their care transition. Also, too, in terms of a lack of involvement in discharge planning, again, that's consistent, not knowing who to contact when problems arise. We've heard a lot, and we talked a lot about that, too, in terms of, who should be the first contact, or what should we do about that as well. And then also, too, delays in follow-up appointments with family physicians, and as well as specialist appointments. So overall, when we looked at the evidence to talk about our context in terms of the data, in terms of quantitative, the numbers around what's going on, the consistency with the sort of more lived experience of people in Ontario with their care transitions, this all came together to really provide us with, we feel, a really robust understanding of our province and what the issues are around care transitions, and then marry that with the quality standards as well. So again, we've talked a bit about the background for the why, and I think most of you, if not all of you, have probably experienced a good care transition and maybe a not so good one, the good, the bad, the ugly. And so basically what we felt we wanted to do with this quality standard is offer a standardized set of statements that can guide us to improve the care transitions in our province. That could be a model for other jurisdictions and globally as well. And so I think the next, here we are, unveiling of the 10 statements. Again, we cannot speak enough around the engagement level of evidence that we looked at, the engagement of people to get to these series of 10 quality statements. I'm going to go over the first 5, and my partner in crime co-chair will go over the last 5. But really, the first 5 are really around knowing the person, right, in terms of that, knowing who they are, in terms of what the information, who they are, also to the assessment, then also looking at how we actually involve patients and caregivers, how we educate to make sure they know where to go, what to look for, and then the transition plan. And I'll just go over briefly each of those 5. So in terms of the first one around information sharing on admission, so this is basically when a person gets admitted to the hospital will share information with the primary care team and home care community providers, as well as any relevant specialist physicians, soon after admission, using real-time communication. I think there was a lot of talk around get rid of the fax. It still exists, but that's the whole, and we could talk about that for a long time. Then the providers in the community and primary care then are to transfer information back, relevant information about that patient, so that it is part of the plan moving forward. So again, something that was debated quite a bit in terms of I think there was debate on whether to put a time frame on that. And anyway, so this is where, but real time, as fast as possible, get that information exchange going as soon as possible. The second one is not surprising, the comprehensive assessment, and this is also physical, psychosocial, and social issues as well as health issues too. So it's a very broad perspective on getting a comprehensive assessment on who this person is, what are their evolving healthcare needs, and what are the social supports they may need to have a successful transition. And this basically starts right when they get in, and then it's updated regularly as they go along. As we can appreciate, in hospital, people's condition can change very quickly. And so it's really making sure that there's up to time, real-time information around what this person is feeling and going through and experiencing. No-brainer, again, like all the data shows that we need to find better ways to engage patients and caregivers in their actual transition planning based on their needs and preferences as well too. So it is a very tailored approach to actually figuring out the context of the people and their preferred level of engagement in the transition planning as well. And then also too, there was a large discussion on the engagement of others. So really that first point of conversation is with the patient on who they want to be involved as their circle of care as part of that planning as well. That was a large discussion point that we had. The fourth one is really around the education. So that's really equipping patients and caregivers, and you'll hear an example after, around what they need in order to have a successful, smooth transition home, and what sort of services they need to be linked into. And then finally, the transitions plan for the fifth one is pulls it all together, a written document that the patient has and caregiver has, so that they have a story and a narrative, because as you can appreciate in the acute care sector, oftentimes you're so sick or ill, you might not remember the information that's coming into you. So if you have it written on paper, you've got actually a written historical document that has your care and your care plan moving forward.
So as you think about those first five, we'll also reference quality standards sometimes meet the current state of practice in Ontario. Sometimes there are statements that might sound, well, we can't do this now, and they're intended to be aspirational to drive us towards better system integration. As you hear about those first five and reflect, and now think about the next five, just have that in your mind. It's not necessarily meant to be we all must do this now, today. Some of these is we will get there together, but we have to set the direction. And so we're using this opportunity to do so. So the sixth one here on the list talks about coordinated transitions. People admitted to hospital need to have a named healthcare professional or a role who is responsible for timely transition planning, coordination of that transition, and communication. Before people leave the hospital, this person ensures, or this role ensures, an effective transfer of the transition plan and the information related to care across that transition point. Really key that there be someone or a role designated to execute this very important function. And so we need to think about, in our own areas, if we're in acute care, particularly, who is that on our team? Or is it a team function but codified in a role? There needs to be some thought to this. The seventh statement is around medication review and support. People transitioning from hospital to home and from home into hospital have medication reviews on admission, before returning home, and once they are home. These medication reviews they're not just medication reconciliation, which the acute care sector is doing reasonably well on admission and at discharge, but it also needs to take into account adherence and medication optimization. How well people will use their medications and how will they access them in the community. This is where we inserted the challenges with affordability. So in reviewing and optimizing adherence, medication reconciliation, a person's ability to afford out-of-pocket medication costs need to be considered, and options to provide alternatives if those costs are unaffordable need to be also considered. The eighth statement here is about coordinated follow-up medical care. We often download the booking of appointments and the chasing and getting into follow-up care to patients who are just recovering from their most vulnerable states. We've suggested here as a statement that people transitioning from hospital to home have their follow-up medical care with their primary care provider and or specialist coordinated and booked before leaving the hospital. so that there is a very clear, and this is what will happen and when it will happen. Sometimes that may not be feasible, but that's the target. If people do not have a primary care provider, we need to provide them with assistance in securing one. The ninth statement is around appropriate and timely support for home and community care. And what we've said here in the standard is that people transitioning from hospital to home need to be assessed for the type, the amount or the quantum, and appropriate timing of home and community care supports that they and or their caregivers need. And when these services are needed, they're arranged before people leave hospital and must be in place, again, if needed, upon returning to home. That might be a slight different approach to how we currently view home care in transitions across hospital to home in the current state. The last statement here is out-of-pocket costs and limits of funded services need to be considered. And information on alternatives for unaffordable costs are included in the transition plans and associated documents. So that, in a nutshell, is the standard and all the statements in there, and again, predicated on evidence from here in Ontario, but also guidelines from other jurisdictions, and quite frankly, a whole lot of feedback when we posted this. So I think we had, and I'm just looking here at the HQO staff, probably around 200, more than 200 agencies, organizations, individuals provide us with very specific feedback. And the exercise of reflecting on that feedback, iterating, reconciling, going back to agencies, saying, here's our latest draft, how does it feel now, has made this standard very robust and strong. It's also helped us with the alignment. We know that the CPSO, for the physicians in the audience, both here and participating remotely, they've recently released their policies on continuity of care that have just gone from consultation to implementation and now to enforcement as of a week and a half ago, and generating a lot of discussion in the sector. The requirement, for example, to have a transition of care plan in place and transmitted to primary community care within 48 hours of discharge is in alignment with the CPSO's continuity of care policies that require a discharge summary to be done within 48 hours. So there's alignment there. Accreditation Canada required organizational practices related to communication, particularly around medication management. OHA guidance documents. As we think about OHTs and their mandates, this is baked in to their mandate. It's like first page, transitions in care from hospital to home. And when we think about the Provincial Quality Improvement Plan, we know for the prior year and likely for the coming year, there will be alignment with transitions of care from hospital to home. So there's a lot of integration baked in to these statements.
So just in closing, and just conscious of time too, just sort of a high-level overview. So through our journey, we discussed a lot of different solutions to addressing the gaps and barriers that we heard along the way from both the quantitative, the qualitative as well too. And so we know there's greater integration that we need to occur, including how do we better engage patients and caregivers in care transition planning, looking at digital solutions to help so that we're not faxing information and having more of an efficient exchange of information, and then looking at how we can have the access to the services that people need, where they want it, how they want it, who they want to buy. And then also to making sure that there's competencies with the healthcare professionals too in understanding how to best provide an optimized care transition. So these are taken into the quality standard. We have to look at it into the recommendations for adoption. And so, for example, two off the top, you'll hear more about. One is the Patient Oriented Discharge Summary, as well as the Going Home from Hospital Patient Guide. And then also a recommendation for creating learning modules for both patients and caregivers that provide care transition and care providers how providing more effective care transitions as well. So now, our job is somewhat done in the standard, but now we're calling on everyone to help act on these quality standards. A lot of people put effort into it, so we want to thank again the committee members. We want to thank the staff. Many of you are here right now. who put countless hours in to make this standard come to a reality, and we're very competitive. We think it's one of the best, if not the best. Anyways, so thank you again for the opportunity to present this.
Thank you.
Wonderful. Thank you, Dr. Ginzburg and Dr. Jeffs. That was really a great summary of a lot of work in 20 minutes, but I think brought a lot of clarity to the work that's been underway. We're going to continue and transition to our next speaker, but I wanted to just very briefly mention, we will have time for questions at the end of this session. For those of you, we have 500 people that maxed out our license on Zoom. So if you're on Zoom, you can use the chat on Zoom. And for those of you who are joining by live stream, I encourage you to send your questions by email to kte@hqontario.ca. kte@hqontario.ca, the same one that we use for each of the round sessions. Okay, and so now it's my pleasure, and we're hopeful that our technology will work for us. It's my pleasure to welcome Bonnie Nichols. Maybe I'll do the introduction while we switch things over here. Bonnie Nichols is the lead for Patient and Family-Centered Care, Patient Experience, Engagement, and Advocacy. Bonnie has led the organization on their Patient Family-Centered Care journey and developed a robust patient and family advisory program. This collaboration with patients, families, staff, physicians, volunteers, and community has really led to improved patient, staff, and physician satisfaction, and Thunder Bay Regional Health Sciences Centre to be the first and only organization in Canada to receive a Patient Family-Centered Care Leading Practice designation from Accreditation Canada. So we're really looking forward to hearing from you, Bonnie, and we're going to turn the control of the slides over to you, and hopefully we can hear you. Welcome.
Thank you, Lee. It's a pleasure to be here today to share with you how we're working to improve the transition to home for our patients and their care partners. Is anybody else hearing an echo? No. To get an insight into Thunder Bay Regional Health Science Centre, I'd like to share with you a few stats of who we are. We're a 375-bed acute care academic health science centre. We provide service to Thunder Bay and Northwestern Ontario, which, by the way, covers 57% of the landmass of Ontario. And you can see the shaded area on my picture that the country of France fits into our coverage area. And we have 2% of Ontario's population spread out over this area. So you can see that alone provides unique challenges. 53% of our population live in Thunder Bay. 19.2% of our population are Indigenous, and 78% tertiary acute care for Northwestern Ontario is delivered by our organization. And last year, our emergency department had over 101,000 patient visits. Patient and family-centered care is not only a dimension in our quality framework, it's our philosophy and the foundation for our care and services. Our patients and families have been our partners on an incredible journey for the past 10 years, sharing their experience, expertise, and themselves. Our partnership has led to improvements in the experience and outcomes for our patients and families at Thunder Bay Regional Health Sciences Centre. So over the past 10 years, we've had a lot of patient experience results and listening to the voices of our patients and families. So we have a lot of information on what their priorities are. And what they've been consistent in telling us over those past 10 years, really much of it boiled down to communication. It was around transitions in care and emotional support. So together we created many patient experience action plans over the years. That's what we called them. And it was based on patient priorities. And each year we developed new patient experience action plans. Some communication issues were addressed really early on with the NOD strategy. Name, occupation, and do, which sets the foundation for any meaningful conversation and aids the patient and their families to know who to have the conversation with. In our organization as an academic health science center, we have many people coming into our patients' room If they see somebody in scrubs, they assume they're a nurse. If they see somebody in a lab coat, they assume it's a physician. So we don't want any communication or miscommunication when a patient may tell a housekeeping staff who wears scrubs also they're having pain and not receiving anything for it. So really, NOD was a real important strategy to begin for the whole organization. Some of the communication gaps were addressed through the development of the bedside communication board and active listening strategies. Other initiatives included transitions in care. We first looked at the transition from the emergency department to the ICU, then from the ICU to the floor, and then now really looking at improving the transition from hospital to home. So this is a slide that I stole or used from the Health Quality Resources Case for Improvement slide deck. As you can see, it indicates the 30-day readmission rate across the province were fairly consistent. There was more variation. Where there was more variation, though, was with the ED visits within 30 days of discharge. A few insights why this is so. For us anyway, according to Stats Canada, Northwestern Ontario patients are sicker. And really, they really are sicker. We have a higher percentage of diabetes mortality, hypertension, obesity, circulatory and respiratory disease, and lung cancer. And you can see here how our rate was higher in that area. We have patients that come into our ED on a daily, for daily visits, like those with cellulitis that come in for IV antibiotics or dressing changes and reassessment for 1 or 2 weeks while they're having this treatment. They're ambulatory and don't meet the criteria for home care services, and there's no other clinics in Thunder Bay to provide this service, and we don't have an urgent care clinic. Patient substance use issues are increasing, and last year we had over 4,000 visits, which works out to 11 visits a day. 45 of these people had a repeat visit within 30 days. Community and addiction services are limited and at full capacity. Patients with mental health issues have been increasing. Last year, we had nearly 3,000 or 8 people per day. And 20% of these people had a repeat visit within 20 days, within 30 days. There's limited mental health services, and our hospital doesn't have a short stay unit, resulting in greater than 100% occupancy on the inpatient adult mental health unit. So we had to be creative and look at strategies that would help with these strategies. One which led to a collaboration with our Canadian Association Mental Health, us and the police. Since June of 2018, a joint mobile crisis intervention team has averted nearly 1,700 visits to the ED. This is one example, and we have several initiatives underway to address our readmission rates. And today I'm going to go into detail to share 2 of them with you. The first one I'd like to talk about is our Patient Oriented Discharge Summaries, or PODS. The original PODS tool was developed by the University of Health Network's Open Lab in a partnership between Health Quality Ontario and the Council of Academic Hospitals of Ontario. And this tool is a tool that was developed to improve the transition to home. It was based on feedback from patients, families, care partners about what was important for us to ensure that they understood before they left the hospital. It has easy to understand written instructions, and there's 5 key pieces of information that we need to make sure are included in the PODS tool so that the patients and care partners know before they leave the hospital. And that's around the medications, what kind of medications to take and how they take them, how they might feel and what they need to do about it. If there's any changes in their routine or activity, who and with what are the appointments that they need to follow up with after they go home, and who do they call or where do they go if they need any help after they've been discharged home. In planning considerations, we were really fortunate to join the Arctic Research Project in 2017. Our plan was to start with our medical units where the most complex patient discharges occurred, as mentioned earlier today, then to spread it to other units, adult mental health, surgery, and other inpatient units. if you're looking to be in this program, there's great resources from the 2 links that I have below. We partnered with our patient family advisors to co-create the process to engage all of our stakeholders, develop the tools, develop the implementation plan, and how we would measure our success. We had a physician champion from our PFCC Leadership Council, as well as other physician involvement to ensure that the appropriate information and condition-specific instructions were included on the pods to make it more individualized to our patients and their families. Point of care nurses and interprofessional staff, including dietitians, physiotherapists, occupational therapists, social worker, and utilization coordinator, also brought their expertise in developing the template. In 2018, our patient-oriented discharge summary replaced all previous discharge summaries on all medical units, as well as on adult mental health. So 100% of our patients discharged from a medical floor received our new PODS tool. Surgery had also begun development of condition-specific patient-oriented discharge summary. We have 28 PODS templates. 13 of the surgical pods have been developed and have been recently implemented, with several more in the process for approval. But we have established 14 medical pods and 1 adult mental health pods that's been in use for some time. What the content of the pods, we have when and why they came to the hospital, information about their understanding about the medications and where they've been faxed to, changes any routine with guidance on exercise or smoking or diet, or whether they need a flu shot or rest or preventing infections. And also on the back, we have areas on there to put the appointments right in, or who they need to contact to make those appointments, and any additional notes. On the back, we used a color coding system like a stoplight to help make it easy to understand what they need to strive for and what is a concern and what they need to do about it. So you can see that on the right, the example of the color coding. Blue is how the patient should feel every day and includes what they should do at their baseline. Green is the goal zone, and it's the expected findings and the symptoms that are under control. Yellow is a warning zone and includes warning signs that the patient may need to see a family practitioner for instructions. And red is the act fast zone, which means you need to see somebody immediately, go to the emergency department. Patients are also encouraged to bring this PODS with them to their follow-up doctor's appointments, because their physicians, their primary care physicians, might not be the ones that have been treating them within the hospital. This slide shows our PODS impact. One of our QIP measures for the past couple of years has been a patient experience measure around our patients' transition to home. And we use the short form question that's written on here. It's, did you receive enough information about leaving the hospital? And this is on the CPESIC NRC health survey. Historically, our surgical units have always performed better in this area than our medical units, because our surgical patients generally have a pathway. They know what to expect following surgery. They know what happens on day 1, day 2, day 3, and what they need to do when they go home. Our medical patients aren't as straightforward, and they have complex issues. Medicine began using the PODS-oriented discharge summaries in 2018. You can see the positive impact they had with their results. They had dramatic improvements since starting the PODS. Surgery didn't see that improvement because they weren't using the PODS tool yet. And you can see at this point in time right now, our medicine is outperforming our surgical areas in this key performance indicator. Another initiative I'd like to share with you is to improve the care transition from hospital home is our nurse-led post-discharge follow-up program. We know that the first 72 hours after discharge is the most vulnerable time for any patient, especially our medical patients. and we have the potential to eliminate an adverse event with a follow-up call after discharge. And we know this firsthand. We've not only improved our experience for all the people that we've called, but we provided education, coaching, and support to over 1,700 people since we started this. And we literally have saved patients' lives. So some of the breakdown of what we found in our evaluation of our post-discharge follow-up program is that first, the process is that we call our medical patients discharged to home, regardless of the unit where they were discharged from, within 24 to 72 hours. We may have may have medical patients on surgical floors, so we want to make sure that we connect with all of our medical patients to ensure that they have the proper education and tools they need to have a smooth transition home. We document the intervention in our electronic medical record, and the purpose of the call is to assess their health status, answer any questions or concerns, check in on their understanding and comfort with their discharge instructions, ensure continuity of their community services or supports, and address any potential gaps they may have with their care needs. The discharge follow-up call is a conversation. You see questions that are written here, but really we don't do it as a question answer period. It's really worked into a conversation. And to the right of the screen, you can see an example of the questions. The responses are also recorded in a separate database because we use it to help evaluate the effectiveness of our PODS tool and processes around discharge planning. And this form is actually a form that we send out to the units so they can see their individualized results, so they can see what they're doing well and how they can improve. We also share comments back with the individual units about what they're doing well and what their patients have said after they've left the hospital. So some of the preliminary results: 95% of the patients called during the post-discharge follow-up this past October required some type of intervention or education. 6% required immediate intervention, sending a rapid response nurse or EMS, or addressing the need for urgent home care. 8% needed help with community resources like equipment rental, informing or assisting patients in the process for limited use funding for medications that they couldn't afford and they really needed to take the medications. But of the 95%, the most common category for interventions was appointments at 86%. This was compounded by the fact that we have a high number of unattached patients. Number two, at 48%, is medications, whether it's about the importance of filling their prescription and taking their medication, or understanding what they need to continue or stop. And we've got some really great stories how this has really saved our patients' life, especially when patients need to take dual antiplatelet therapy after post-PCI. Sometimes it's about educating them about their medications and why it's so important to take them, or how they need to take them. Or it might be about filling in the gap where the local pharmacist says they haven't received the fax, and we can track it down and ensure that they receive it so the patient can get their medications. So bundling the practice, this is a slide I just wanted to share with you. We've implemented many initiatives and tactics that would help improve the transition to home for our patients. And you can see we've had some success, but it wasn't sustained, sorry. But when we bundled the post-discharge process with the PODS, we really started to see a continued improvement. And I don't have it included on this chart, but preliminary results for Q2 of 1920 are following the trend of improvement. So some of the lessons we learned include all the stakeholders. Make sure that you include them. It's not necessary that they come to every meeting, but you need to consult and seek their input. Involve your patients and care partners from the beginning, as well as the point of care staff, because they're the ones that are going to be using this tool. The day of discharge is too late for our patients to receive the PODS tool and understand all the information. Nurses may be rushed in that process. and bundling the practices improve results. The Canadian Foundation for Healthcare Improvement is currently doing a pan-Canadian pilot called B2H. It's called Bridge to Home, and it includes what we've talked about during this webinar about bundling best practices. And their bundle includes patient and care partner engagement, teach back to ensure understanding of the patient, patient-oriented discharge summaries, post-discharge follow-up calls. And one of the most important lessons that we learned, and I'm going to quote our EVP of Research, Quality, and Academics, CNE and PFCC, Dr. Valgardiza, don't boil the ocean. So our plan for the future, we're going to pause and see where we are and evaluate our current tools, processes, and results. We want to look at what a pre-pods may look like. That's kind of a name that we've given it, but giving a pods earlier in the process so that we can utilize it as a teaching tool throughout the admission. Develop a re-engagement plan based on our evaluation, and monitor and evaluate a bundled approach to teach back, pods, and post-discharge follow-up calls. And the last slide, if you adopt the best practices that we've just talked about, you'll be contributing positive actions within the draft quality statements. And I have them listed here and bolded out. And I will leave you with a picture of our beautiful city and open it up to any questions you may have.
Hi, is that working now?
Yeah.
Okay. Yeah? Okay, that's great. Thank you, John. Okay, great. So look, I think we've got time for one more question. Actually, I'm sorry. Let's redirect the question back to Bonnie, please, if you wouldn't mind repeating it for her.
So, Bonnie, what advice do you have to engage physicians in the discharge process so that they have an opportunity to provide information and input in the discharge plan?
So for ICU, the PODS tool in the ICU, we developed improvements in our transition to the ward, not with that particular tool, but we did include the physicians in the development of what kind of information do they need the patients to understand when they're going to the ward. Is that, did I answer your question? As far as the PODS tool for the rest of the organization, it's really important for the physicians to be involved because especially the cardiovascular physicians really helped guide what kind of signs and symptoms patients needed to go to the emergency department for, or what their target was. So they were critical in ensuring we had accurate information on the back of the PODS tool so that they would know what they would need to do.
Thank you. Maybe one last question?
Sure. The question is for Amir and Lianne. I'll redirect back to you. In the development of your standards, did you look at any non-medical needs of patients going home? For example, were there any discussions about how to include meals, housekeeping, transportation, and these IADL supports in the discharge plan?
Yeah, those did come up for sure. We heard that through the concept mapping as well. So complex subject to tackle. They're not specifically called out in the statements themselves, but everything around that transition plan is probably where that would live. So transportation to and from appointments, supports, meals, it's kind of bundled into the community support services that people would require. And that is one of the cornerstones of the transition plan. So I think you'll see some narrative around that on the fifth quality statement.
Yes, and home and the number 9.
Right, and
home
number
and community care.
Yeah.
Right.
And just to sort of add to that too, in terms of certainly just with respect to the concept mapping, also identified, as I mentioned, the out-of-pocket expenses, as well as relying on charities, so like Meals on Wheels and that, and other service-based, to help augment the social aspect of the care transition, in addition to the medical needs as well. So it definitely was discussed, and hopefully has some prevalence in the statements that were recommended.
Okay, great. I think what I'm going to do is wrap the session up for today, but as we've mentioned, we want to keep this discussion going on forum. Usually we try to respond to some of the other questions that we've heard through that means. And I really feel this is just the beginning. So for those of you that we piqued your interest, you can access an updated draft version of the standard on the HQO website. It's there. Go and have a look. You'll be hearing more and more from us as this is more formally launched across the system. Again, I think Amir did a nice job of making the connections to some of the areas of priority across the system right now, and what it connects to and is relevant to. And there's no question, as we work to improve integrated care, hopefully the standard can help to guide many of those discussions. So at this time, I want to say a huge thank you to our three speakers. Thank you to Bonnie up in the north. Thank you to Amir and Lianne for joining us here today. I just want to say a huge thank you. I want to say a big thank you to all of you that have taken the time to join. I know in our room here we have a grade 9 student with us as well who joined as part of the Bring Your Children to Work Day. So if there's other kids out there that have joined their parents today, hopefully you learned something about transitions in care. For those of you that enrolled for the session today through Zoom, you will be receiving an email with us to provide us some feedback through a survey about the session. And then finally, you'll be hearing some more from us in the new year about our next, more information from us soon about our next quality round session that will be hosted early in the new year. So thank you again, everybody, for joining. We really appreciate it. Thank you to the team here at HQO for all the work that you did to organize and put this on today. And have a great afternoon, everyone.
Recording has stopped.